I have the great honor and privilege of introducing our capstone keynote speaker for this year's Global Health Policy, and that is Dr. Francois Bompart. As you'll see, that'll be coming up, his bio, if you haven't had a chance, please take a look at his bio online. I mean, he's here to offer us suggestions on how to meaningfully tie this all together, right? Sustainability, innovation, access. He currently sits as the Access Committee for the chair at the Drug for Neglected Diseases Initiative, DNDi, where he works to contribute to discovery, development, and distribution of urgently needed medicines, and working really to address the needs of the poorest of the poor. So his 25-year career really has been working to support low resources and vulnerable populations, with special attention to pharmaceutical access to healthcare initiatives. So, Francois is a trained physician, he's a pharmacist, and he has deep experience in the private sector, primarily from his work with Sanofi, and his leadership has really contributed to the creation and chairmanship of the Global Health Initiative for the European Federation of Pharmaceutical Industries Association. So, thank you, Francois. It is an honor to have you here with us today, and I'm very excited that you were able to join our discussion. So off to you.
Thank you very much, Veronica. I think some slides are going to come up, but before they do, I'd like to take this opportunity to thank you, and also thank EJ Ashburn for the great privilege it is to give the final remarks after such an exciting series of 3 days of talks, of exchanges, of really very interesting insights shared. So it's a really big privilege. So I don't know if, I see the slides coming up somewhere. So thank you, Chelsea. I could have entitled this talk, Global Health, a View from the Drugs for Neglected Diseases Initiative, because as you've said, I work at DNDi at the moment. And it's interesting to remember that in his opening talk, Robert Mallet talked about access. I too will talk about access, but through the prism of neglect, to echo what he said about access. And I think this prism can be interesting to address some of the key issues related to healthcare. So Chelsea, if I can get the next slide, which is about a few words about DNDi. For those of you who are not familiar, DNDi was created in 2003 with the award that MSF, Médecins Sans Frontières, got with the Nobel Prize in 1999. And it was born out of frustration on the part of MSF physicians in the field who did not have access to safe and effective drugs, or maybe sometimes the drugs were existing, but they were not adapted to the needs of their patients. And MSF being what it is, there is a clear also political vision behind the creation of DNDi, which is to challenge the status quo and to say, next to a profit-oriented pharmaceutical market, there needs to be something else that exists to take care of the poorest and the most vulnerable patients. So the next slide, please, is to tell you that DNDi started working on neglected diseases, and malaria was the first disease, which has now been handed over to MMV. But we worked a lot on the sort of classical neglected tropical diseases: sleeping sickness, filaria, mycetoma, leishmaniasis, Chagas disease. But after a few years, we included also neglected patients. So these are patients who are not suffering from one of the labeled neglected tropical diseases, but who are neglected. If we can take the example, for instance, of very young children affected by HIV. We don't have these children anymore in the industrialized world, but there are tens of thousands of kids who are born in Africa every year affected with HIV. And until very recently, there was no child-adapted formulation to treat young infants, to treat young babies. So this is the type of neglected patients we have included also in our scope, as well as patients suffering from hepatitis C, for which we have really miracle drugs, but which are not available enough where they are needed. The next slide, please, Chelsea, is to say, DNDi, and you've said it, Veronica, is an R&D organization. So why is access relevant for us? Why should we bother about it? First of all, because the founding fathers of DNDi, created it as an experiment in innovation for access. They really saw the end result of the R&D efforts. As we all know, of course, research and development and access issues really go hand in hand. There is no way you can properly develop a drug or a vaccine or even a diagnostic test unless you understand really well what are the end users' needs you have to meet. Of course, we have also moral duty to ensure that our drugs reach patients, but very importantly also because we depend on funders. Our funders want to see where their money goes and what is the impact of their investment. And that impact has got to be very logically in terms not so much of how many drugs have you developed, but how many patients have you treated and how many lives have you saved. So the next slide, Chelsea, please, is to illustrate our challenges. We all know, and the past 3 days have been great in making that point. Access is an incredibly complex and rich field, but it's even more complex for DNDi. First of all, because access to care happens or does not happen at the local level. It happens in countries or it does not happen in countries. And DNDi is not an organization with a lot of in-country footprint. We are largely a virtual organization. It's not our job to be in the field. We're not present in every country where we are targeting patients. And each country, of course, has got its own specific determinants of access to care. We oftentimes tend to generalize too much, and we those of us who know the field know that there are no two countries are identical, and each country has got its own specific determinants of access to care. We deal also with many different diseases, many different medicines, and each of these diseases, each of these medicines has got its specific determinants of access depending on how it is administered, how it needs to be stored, and so forth. Also, we are a partner-based organization. I've said we are a virtual organization to a large extent, so we work with lots of pharmaceutical partners. Some of them have got a lot of in-country footprint, others don't. And for those companies which have no country footprint, generic manufacturers, most of them, their ability to actually ensure access beyond supplying drugs is very limited. And to cap it all, by definition, we work on neglected patients, and neglected patients obviously present additional challenges because by definition, they are excluded from the normal healthcare systems. So if you would like to click once, please, Chelsea. Oh, well, you can click twice, but that's okay. Once, there should have been something that said Mission Impossible, and that was supposed to be funny. And then there was this jigsaw puzzle thing that would come up to say, the mission is impossible unless you find the right partners, and the solution to our problems are really partners. So to find the right partners, and that's the next slide, please. Can you click on the next? Thank you. Yes, we have developed an extremely simple framework to describe what access to care means for us. Access to care, I couldn't find a simpler way to describe it than to say, it's whatever stands between a patient and a drug. And the simplest way I've found to describe it is to say access is made up of 3 key levers. The first one is demand. Someone must prescribe a drug for a patient, and that means that someone must have made a diagnosis for a patient. And that's often where we have a problem, lack of demand, lack of diagnosis. Once the drug is prescribed, then someone must bring it to the patient. And of course, all the costs must be covered. And this makes up for an incredibly complex chain of events, which are different in every country. That is very complex to set up and very easy to break. One missing link in that chain is enough to break it. And to illustrate what I mean, yes, thank you. I'm taking the example of demand. For demand, we've taken very simple, but which are in fact very complex at the same time, sets of issues. First of all, what is the level of disease awareness? Do people know about the disease? Political decision makers, prescribers, communities. Where do patients get diagnosed? How much does that cost? What are the treatment guidelines? Are the treatments adapted to caregivers and patients' needs? Who prescribes the treatments? Do prescribers know how to use the drug? What is its proper place in the armamentarium? And what makes the adherence to treatment good or bad? These are very simple things, and we've got the same type of things for supply and for finance. But that helps a lot, simplify the issues, knowing that we need to go through these steps, this sort of checklist, country by country. Again, each country is different, so we need to go through that list for demand, for supply, for financing, country by country. And it's only then we've done that work that we have a good enough idea of the obstacles. Instead of writing masterpieces to describe it country by country, what is the status of all these levers, we focus on obstacles. What is the problem with diagnosis in a given country? And going through these steps helps us a lot clarify our own thoughts. And so the next slide, please, should show you what are the first lessons we have learned. The first one is that for us, for our patients, demand diagnosis is really the key issue. That's where it all starts. And in that regard, it's interesting to bear in mind that whether we want it or not, HIV has shaped the views that many people have over global health in the past 20 years. We all know, of course, how much we owe to courageous and articulate HIV activists when it comes to improving global health. But HIV is an exception among diseases. Demand is not the biggest problem for HIV, but at the same time, people don't take to the streets to demand medicines for most diseases. So HIV has been an incredible positive factor for change, for the betterment of global health, but at the same time, HIV is an exception. And for the neglected diseases and the neglected patients we deal with, the lack of demand, the lack of diagnosis is the root cause for lack of access. The second thing we have learned is that we need to be very clear and very simple in the way we explain the problems if we want to find the right partners. Also, we absolutely need to have partners who are present in the countries where we operate. Access does not happen because I've thought about it in Geneva or in Paris or in New York. It's in the country that you need to have the people who know what is going on and who can really design the proper access plans for you. So we absolutely need, because we don't have so much presence in the field ourselves, we absolutely need partners who have in-country presence. Another thing, of course, is that unlike, for instance, drug registration, access is never done. It's never achieved. You need to ensure its sustainability in ever-changing environments, in a myriad of different countries, and so forth. And last but not least, and that goes back to the initial roots of DNDi, we are very, very aware that ultimately what drives demand, supply, and financing are political decisions. And I'm going to come back to that in a moment. So the next slide, please, Chelsea, is about COVID-19 and global health. I'm not going to try to summarize everything that has been said over the past 3 days. Just highlight a couple of issues. We all are more aware than ever before that we live in a global village, but also how incredibly diverse this village is. Equitable access to health has come, and very rightly so, to the forefront of many people's attention, and that's absolutely great. We have also come to appreciate, for those of us who are not convinced, of the vital role of governments in public health decisions. We have also seen the power of partnerships, and we must highlight in what is happening with COVID the incredible role that both the private and the public sector have played in finding solutions. The only thing we can probably regret is that non-governmental organizations and mainly civil society has probably not been involved to the level it could have been, and that's a lesson maybe to bear in mind for the next time, which hopefully is in the very distant future. Last thing I think, which I want to highlight regarding COVID-19, and what at least for me it has highlighted, is of course the need for better coordination when it comes to policy and access. I think we have seen that over the past 3 days. But one point I wanted to highlight also is better coordination is needed on R&D. In the first few months of the pandemic, I did a search, and I found that there were hundreds and hundreds of clinical trials, all trying to achieve the same objective, which was to test chloroquine or likewise or some old drugs in patients. Do we really need several hundreds of trials to prove that? I don't think so. This was just a race for people to either feed their own ego or to go after money, which was available at the time. But in the end, it was an incredible waste of opportunities, incredible waste of money, incredible waste of time. And I think I haven't done properly my homework on all of these, but I think there is one country which stands out as being one country where public money was directed, where the public health decision makers said it had to be targeted for each trial. There was a decision made. This was the UK. The UK said, here are the priorities we have. Here are the types of trials we are going to fund, and we're not going to fund 20 trials. We're going to fund one really good one, and that's it. And I think there is a lot to remember in the future for this. We need better coordination also on research and development. So the next slide, please, is what next? Of course, we have discussed that a lot over the past 3 days. I won't even venture to try to guess what the future world would look like, but there are a few things which are pretty certain. The first thing that is certain is that new generations are going to take over, and new generations will mean different ways of working, new standards, different fields of interest. we can bet that these new generations are going to be more sensitive than probably we were about equity-related issues regarding gender, origin, north-south relationship, and so on. And also these new generations will have views of global health which will not have been framed primarily by the HIV experience, however transformative that experience was. We can also expect this generation to be much more interested about global warming. Global warming will be a major driver for change on many fronts, and bearing in mind that it will, of course, affect disproportionately the most vulnerable people. And another thing which we can anticipate probably are new partnership models. Again, the COVID crisis has shown how incredibly powerful good collaboration between the public and the private sector is. But we must also realize that many of the bodies we work with, many of the product development partnerships were created at a time when philanthropy was high on the agendas, and vertical programs were seen as a fast solution to problems. And we can guess that this is going to change pretty soon. Chances are that people will want to move away from single disease, single modalities, for instance, treatments, vaccine or diagnostics tests, to address problems in a more holistic way. For one thing, we can expect that money is going to be more scarce than ever when it comes to global health, and funders will want to have a clear demonstration of the impact of their investments in terms of life saved, of patients treated. So chances are we are going to be going towards more holistic either organizations or at least ways of working to achieve access in the end, because that is what matters in the end. So the next slide, please. I started off talking about neglect, and in closing, let me go back where we started. We started with neglected diseases, then neglected patients, and let me now talk for a minute about neglected people. I put this slide very quickly to express just a few things. The first one is that there are lots of reasons why people do not have access to the healthcare they need. It may be because they are poor, because they live in the wrong place, because they are stigmatized, because they are young or old, because they are displaced. There are many, many, many reasons why people do not have access to the healthcare they need. But the second point is that many people, and of course the poorest ones are the first, are affected by multiple problems, and very few people are immune from some risk of neglect. Even me, as an incredibly privileged person, a white male professional living in a high-income country with universal health coverage that has been there forever, I can relate to at least two potential causes of neglect, because I'm first of all over 60 years of age and I'm gay. But of course, my little problems are absolutely nothing compared to those of the most destitute people who accumulate multiple problems which require multiple interventions to fix. And same as I was saying earlier about a complex chain in which one link being broken is enough for the whole thing to not work, one of the problems for the poorest people not being addressed means that they will not have access to care. And if we look at possible solutions, which are on the right-hand side, you can see there are multiple ways to address neglect. Some of them have got to do with research and development. Some of them have got to do with education. Some of them have got to do with peace and to war and peace, or to peacekeeping operations, IP barriers, stigma, law, economic development for many of them, of course. And so, we see that the problems are multiple, the possible interventions are also multiple. But I would submit to you that there is one dimension that cuts across all causes of neglect. And if you'd like to click, Chelsea, please click just once. No, it doesn't work. Okay, well, that's all right. There was an illustration here to show that the one dimension that cuts across all causes of neglect is politics. Yeah, thank you. If some people are left behind, it is because political decision makers have made, or more often have not made, decisions that have enabled them to be taken care of. These are issues of funding priorities, of course, of visibility, but more profoundly, as was said in the previous roundtable, of human rights and of social justice. And the only way neglect can be addressed is through political choices, political decisions. To take again an example with the UK, the UK, well before COVID, made the deliberate decision to make mental health a national priority and actively fight stigma affecting people with mental disorders. And this is a clear example of how neglected people can get out of the shadows if politicians are convinced this is an important thing to do and an important thing to fund. And to finish, it may be interesting for us to contrast medical practice and public health. In medical practice, one cares for one individual at a time, and we're not satisfied until each individual is cured. In public health, we deal with millions of people, and we are pretty content when most people are taken care of. We don't worry so much about the ones that are left on the side of the road. We have done what we could, and that's probably not so bad, but I don't think this is right. I think the only way out, the one goal we should all pursue in everything we do, and that has been said earlier, of course, is universal health coverage. And if you'd like to click for one last time, Chelsea, please. When I say universal health coverage, I mean equitable, sustainable, and truly universal health coverage. And given how global health intersects with all the dimensions of life, as we saw just in the slide before, aiming for nothing less than universal health coverage is the way that we together can make a better place. We need to keep advocating in everything we do for universal health coverage. And to echo E.J. Ashburn's opening words, because we deal with multidimensional issues, we can only succeed through multidimensional innovative partnerships, which these 3 very exciting days were all about, thanks to PQMD and their partners. With this, thank you very much, and I'll hand over to E.J.